Welcome everyone to this webinar of today entitled Ibarukeneza Mubyeyi, which means may every woman have a healthy birth. To the Rwanda Group Antenatal and Postnatal Care Trial. So welcome. We have a list of presenters today. So welcome everyone. We have our presenters, who is Felix Sayinzoga from Rwanda Biomedical Center, who is one of our speakers today. Sabine Musangi from University of Rwanda, and Maurice Bucagu from University of California, San Francisco. Next is Sabine. Okay, we will also have our guest speaker, Dr. Maurice Bucagu from World Health Organization, and Jeff Smith from Bill and Melinda Gates Foundation. So welcome everyone. And so before we proceed now, I think I will welcome at this point Dr. Dennis Walker to give us the first talk on this webinar.
Great. Thank you very much,
Dr. Davis.
Thank you very much, Dr. Relisa, and welcome to everyone. I want to send a special shout out to any of you in the audience who may have been involved in this study, particularly any of the midwives or the group care trainers or the field workers. I just wanted to say a very special hello to you, because without you, this work would have not come to pass. So I'm just going to very, very briefly introduce you to the sort of the motivation for this study. As some of you may know, it's part of a larger portfolio of work through the Preterm Birth Initiative East Africa, where there was a large implementation trial conducted in Kenya and Uganda, and then this large trial that was conducted in Rwanda. And our task for that larger project was to really address the burden of preterm birth. And after many discussions and meetings with our key stakeholders in Rwanda, it became clear that working towards an effort or an intervention that might actually prevent preterm birth was where their interest was. So how and where interest in group antenatal care for the prevention of preterm birth, really it has been a growing field of interest and inquiry. In 2015, there was a Cochrane review that revealed that there was no overall effect on preterm birth of this group antenatal care model, but it did have very high acceptability and there were no adverse outcomes. Women really seemed to like this model. It did, however, show that there were lower rates of preterm birth among women that were at particularly high risk. This was all in high income settings. And in compared to individual care, the risk of both preterm birth and low birth weight was decreased. And that was even more so among women who had more than 5 visits. So since that Cochrane review, there has been actually quite a bit of work that has come out. There's been lots of feasibility, acceptability in low and middle income settings, Ghana, Tanzania, Malawi. There was a recent CRCT that was powered to detect facility-based births in Nigeria and Kenya, and it in fact did result in higher facility-based birth rate and increased coverage of the 4 antenatal care visits. So with that very brief context, I'm going to pass it over to my colleague, Dr. Felix Sayinzoga. He's a medical physician. He's a senior officer of maternal health, and he's the acting director of the MCH, the Maternal and Child Health within the ministry at the Rwanda Biomedical Center. And I want to appreciate especially Felix and Sabine, who you'll be hearing from later, who really, it was their leadership that allowed this trial to be conducted and the results that you're about to see. So Felix, I hand it over to you.
Thank you, Doris. Thank you everyone for attending this call. Thank you also for the organizer. So as Neil says, this Rwandan group antenatal care known as Ibarukeneza Mubyeyi model was developed by different partners, especially stakeholders from the central level, but also nurses, midwives, clinical experts in obstetrics, pediatrics, and radiology. This was done jointly with the technical working group. So at that time, the National Antenatal Care Guideline in place offered for antenatal care visits. The first visit was an individual visit, and this when women are invited to participate in group care, and after, if they agreed, they were assigned to group based on their gestational age. So the following visit, meaning the second up to the fourth, were done in group, and the group was composed around by 8 to 12 women. It's always started by a self-assessment of weight and the blood pressure, and then following by a brief check with a nurse behind a privacy screen. And then there was a 1 hour group discussion on nutrition, birth planning, and also remembering to women some danger sign during pregnancy. So the last visit was done in postnatal period at 6 weeks, because the postnatal care guideline in Rwanda scheduled the fourth postnatal care visit at 6 weeks to coincide with the schedule. Next. So we conducted our RCT in 36 health centers across 5 districts. Those 5 districts were selected because there were not really other intervention implemented by other partners. And our primary outcome was the gestational age at birth. So we have 2 main groups. One with standard antenatal care, and the individual antenatal care, and the other one with group antenatal care. So 2 interventions were added, especially the screening with ultrasound and the use of urine pregnancy tests in community. The first one was used to make sure that we make more attractive antenatal care, and they also measure the executed with the gestational age. And the second one, the urine pregnancy test in the community, was mostly to make sure that we take early pregnancy in the community. So in the half of the sites, one was using ultrasound, another one urine pregnancy test, ultrasound and the urine pregnancy test, while the other one was not using one of the 2 interventions. Next. So in our study, our hypothesis was that increase coverage of screening and the treatments and also repair will the chance of identification of risk factors and the prevention of complications that can lead to the termination of the pregnancy a little bit early, so making longer the gestational age. And this was, we were thinking that at least the gestational age will be increased in the group antenatal care by 0.5, which is at approximately 4.3 weeks compared to women who receive standard antenatal care. Next. So we started with 55 health facility, but during the assessment of those health facility, we kept only 36 health facility, and then there were assigned to group antenatal care or individual or standard antenatal care. And then we added the two intervention. And at the end, we had 8,843 mothers and newborn whom we assess the outcome. So the study was conducted in health centers, which most of them were located in areas, 78%. And all the health centers, the health workers, the type of health workers in those health facilities were nurses or midwife. We do not have physician at that level. And there were government or missionary facilities. And they normally provide uncomplicated vaginal delivery only. If the woman needs cesarean section, they always refer the woman to the next level, which is the hospital. On average, the distance between the health center and the referral hospital was about 30 kilometers. And they had a monthly delivery volume between 35 and 125 beds. So the data we collect and we are going to present the result are coming from the enrollment survey, which was done at the beginning, and also the content of clinical visits from registers, and had also some subsets of participant survey, and also a qualitative work that was done at the baseline and 9 months after, and also at the end of the study. That was on the side of women. On the side of group antenatal care, there was a group visit debrief completed by providers, and also observed group visit by master trainers. We had also some data on the side of providers at the beginning, and they also 9 months after, and at the end. And then also we did some work at the beginning and 9 months later, and also at the end of the study. So I'm going to end to my colleague, Dr. Sabine Musangi, who was also the principal investigator. She's from the University of Rwanda College of Medicine. Over to you.
Thank you, Dr. Felix. So I would like to welcome again everyone. So we are pleased to have you with us in this webinar. So I'm going to present the results. So first, I would like to show the primary outcome papers that was published this year in February in the PLOS ONE journal for your reference. So 86% of women in our sample were insured through the community-based health insurance, the National Community-Based Health Insurance in Rwanda. And you can see that also most of them had a primary education level, primary education or less. And most of them were between 18 and 35 years old. 28% of them were nulliparous. So the results of our RCT show that group care was not able to increase gestational age by half a week, as we have that in our hypothesis. You can see that the two means are very close, and actually almost identical, and the p-value is not significant. So what we are seeing also is that group antenatal care did increase attendance to 3 antenatal visits, but not 4. So 81% of pregnant women in the intervention sites attended 3 visits, compared to 72% in the control sites. We also found that group care did not affect entry to care, because you can see that though a few more women in control sites, attended the first ANC before 14 weeks of gestation, but this was not statistically significant. So you can see there is 42% in the control site and 37% in the intervention site. So group ANC did not change attendance to 4 ANC visits, but also to the 6-week postnatal care visit that we had. And actually what we observed is that group care may have made PNC difficult, because in we were actually using the gestational age at ANC1, and women's were grouped based on this gestational age, and those gestational age were not close enough to make the timing of the postnatal visit align correctly. So that's why PNC was quite difficult, group PNC was quite difficult in intervention sites. So these are the results related to the secondary interventions. So what we are seeing is that ultrasound, basic obstetric ultrasound and urinary pregnancy testing did not affect attendance. And also early entry to care. So what we are seeing is that women in the control sites, sorry, I have something in front of my screen. What we are seeing is that the proportion of women in the ultrasound sites has attended, women in the intervention site, a few more women attended ANC1 earlier in the intervention site compared to the control site. However, these findings were not significant, statistically significant. So we have 41.2% in the intervention site and 37.8% in the control site. So the model, our intervention was monitored by a group of master trainers who were trained in group care, and then subsequently they trained the nurses and midwives in these health facilities. So they were able to observe 150 groups. This represents approximately 5% of the group, and they scored them with an average fidelity score of 3.17. So in total, we had 2,788 group visits. So each of the group visits had on average 9 women, and 90% of them were co-facilitated as planned by one provider and one community health worker. So among the pregnant women we sampled for our survey, so 95% of them said that they would prefer group ANC for their next pregnancy. So they were happy with this mode of delivery of ANC. And on the other side, on the side of the providers, so actually we had 86% of them reporting group care as the mode of delivery that they prefer. So along the trial, along the implementation of the trial, we did some qualitative work. We did at the baseline, midpoint, and also at the end line to get the perceptions of women and providers before and after the implementation of the intervention. And here we have a quote that is coming from one of the work that we conducted, and it's coming from a provider. It's really interesting for us because at the beginning, one of the challenges that was reported during the qualitative work that we conducted, especially coming from women, was the fear of having a lack of confidentiality. So, and then what we are seeing with this quote is that actually the groups discussed very personal topic, and women even discussed topics around mental health and stressors. So we also looked at the Edinburgh postnatal depression scale that we actually assessed in a subsample of the women that were participating in the study. And we did that both antenatally and postnatally. So the results are showing that, showing us that group care may decrease postnatal depression. However, these results warrant further investigation because we didn't have, our sample was not large enough to achieve significance at the effect size that we observed. So here we have some additional quotes coming from our qualitative work. And the way we are presenting them here is that the two at the top are the positive one, a sample of the positive quotes, and at the bottom we have a sample of some of the negative aspects of group care that women discussed about. So it's really, I have highlighted in yellow the section of these quotes that are really interesting. For the first quote, for example, we have a pregnant woman saying that being in group care helps you to get more knowledge from others and from the nurse who takes time to talk to you. So this is something that came back again and again among pregnant, actually the women. It was this ability to talk to the nurse and to feel that they are more comfortable with them. With this hierarchy that we tend to see in the medical field was not there anymore. So women were feeling really comfortable to talk to the nurse and even to call them sometimes. So the second quote is coming from a provider, and she reported that, she said that today women, they feel, so this is women feel at ease with the nurse and they behave like friends. So, and still among these women, some were still a little bit, feeling a little bit challenged by the group, especially in terms of fearing lack of confidentiality. Here there is a woman saying that women are too much talkative, and you can see one of us spreading my story. And the second, actually, negative aspect here that we have is that it was taking too much time to start the group care and go over the 2 hours. And for some women, that was too long because they had work to do at home or they had to go back to their children. So on the side of the providers, actually, they were kind of positive. However, they presented some challenges, especially related to workload. So in the setting where this trial was implemented, an ANC provider may work in more than 2 services, more than 1 service. So for example, if you have a provider, ANC provider, ANC provider can also oversee another service during the same day. So for example, family planning or maternity. So then because of that, they had to sometimes leave the group and go and attend to the patient or client in the family planning service or the delivery room. So this is something that was really a burden on them when they were doing these group care visits. And here, this is a quote coming from one of the providers and highlighting this issue. So I think what we can say from the experience that we got from the implementation of group care in Rwanda, we can say that we had a successful implementation of this intervention, as we observed a good level of model fidelity, but the did not increase, especially in this general population, because all these women, we found out that these women were representing a low-risk population in general. So we followed the national guidelines for the group care, and especially for the number of visits available. So we had to implement 4 ANC visits. And when you look at the literature, especially in places where they found that an impact on preterm birth, so they said that this was achieved by a dose of approximately 5 visits. So maybe the dose that we had in our study was relatively low, and maybe this is why we were not able also to see any impact. So we have also to note that we have some contextual factors that may have also impacted our study. For example, the registers, the ANC register that we were using as our data source are not flexible to capture additional visits. So we couldn't, even if visits were made by women. So also the second one is that Rwanda, unlike other African countries, in Rwanda, ANC is not free. So women, most of the women that we had in our sample actually were insured, but even if they are insured, they have to pay a copay, which is not a lot of money, of course, but still this is some cost. And the women who don't have any insurance will have to pay the full cost. So Rwanda has also a performance-based incentive program. So these pay some incentives to providers for the quantity and quality of services provided, and this may have had some impact also in our findings, as we don't know exactly how it has influenced the behaviors of women and providers. So also the last one is that when we're implementing group care, so we experienced a staff reallocation between health centers that was actually conducted by the Ministry of Health. And as you all know, we don't have any control on factors like that. So, and I think finally also we have also to acknowledge that behavioral interventions maybe need more time to see some impact, some changes, and maybe that's what we didn't have in research. So now I would like to pass over to Delis, who is going to close this presentation. Thank you. Over to you, Delis.
Great. Thank you very much, Sabine and Felix. And before we transition into getting some reflections from some of our other panelists, I'm going to conclude here, but I want to remind everyone, if you do have any questions or observations that you'd like to bring up, please do go ahead and use the Q&A function, and we'll be monitoring that, and we'll either answer those questions in the Q&A or take them here in just a few minutes. So I think that hopefully what you've been left with is that this is a very intriguing model for antenatal care with lots and lots of potential that probably has yet to be realized and has yet to be understood. And some of, as our team got together and thought and rethought about the results, and certainly there are lots and lots of results we were not able to show you today, but there are a few kind of underlying principles that if others are exploring this work, maybe should consider as areas to go. And one of that, which seems to be the most obvious, is this idea of the dose of the group ANC, that the 4 standard ANC visit that had been recommended at the time of this is just probably not enough. And it's great that the new recommendations are now talking about 8 contacts. So that provides a sort of a policy approach that might make this something that could be realized. I think also the fact that in Rwanda, I think this was a group of fairly low risk women, and the impact may have been different if it was a sub-select group of higher risk women, and that should be considered. You saw Sabine mention the potential impacts on mental health, but I think there's lots of other indicators that we just didn't really have our eye on, that there are some signals coming through. And those are things with regard that others should be measuring about infant well-being and development. We spend a lot of time talking about, okay, is this experience with group antenatal care impacting this pregnancy, or could it actually be impacting a future pregnancy? And again, as with all of these interventions that aim to improve quality, it's not just a meeting, it's actually the quality of that meeting and the content of it. So I mentioned about integrating into the 8 contact model. I think the Rwandan model, in which community health workers were trained as co-facilitators, was a real positive element of this. And this, you know, we did have quite a lot of additional work about what that was like, co-facilitating between a nurse midwife and a community health worker. I also think that, you know, a lot of people say that it's basically the same resources to do group care and individual care. And I think the truth is it's not. It requires a fairly significant human resource to really focus and focus on this 2 hours of group care that is important for its quality. And the reorganization does take significant system adjustments and in order to really build a sustainable model. And I think that health systems are going to need to decide if the higher quality is worth the potentially increased resource that is required to do that. And I think finally then is it will be interesting in the years to come to look at some of the areas that actually do move towards a group care model and see what happens in a much more mature system in which it is really the standard and is not something that is perfectly new. So with that, I just wanted to call your attention to the full report of this project. So that is available now, and if you did sign up for the this webinar, you'll be getting a link to how, if you're curious about some of the other data that we collected and findings, you will find that in the report to a detail that is not in our publication, in addition to another list of publications that we have done. There are some others that are in the works, but you can see that there are a number of publications that have been done. So with that, I see this is great that I see some questions coming in. Elizabeth Buttrick, who was the senior program manager for the project, will answer those that she can, and then we'll pull some of those into the panel. What I'm going to do now is we have 2 very distinguished panelists that are going to provide some reflection on this intervention for us. The first is Dr. Maurice Bucagu. He is a medical officer for the maternal health unit of the Department of Maternal, Child, Adolescent Health and Aging at the World Health Organization. Dr. Bucagu, welcome. We're curious to hear your thoughts on this topic. Pass it to you.
Thank you very much. For the audience, I'm really very pleased to join this webinar today on group antenatal care. And that was conducted in Rwanda. From the WHO perspective, and in reference to the 2016 WHO recommendations on antenatal care for a positive pregnancy experience, the group antenatal care provided by qualified healthcare professionals may be offered as an alternative to individual antenatal care for pregnant women in the context of rigorous research. And I'm really glad that this is what was done by your group. And I want to congratulate you, the Rwandan team and all partners for the excellent work that was done, showing actually that the group antenatal care is a strategy that is feasible, acceptable, and with high potential of client satisfaction and positive pregnancy experience. So I know Rwanda has recently adopted the new WHO 8 contact model, but now the challenge is how to implement it. The issue of inadequate human resources, as has just been mentioned, for implementing the group antenatal care remains a major challenge, as well as other resources, particularly in the 8 contact model, if the 8 contact model is to be successfully implemented. Also, the context of this COVID pandemic would definitely not help for the group ANC approach. So all this to us calls for innovation and implementation research needs. I really do hope that the implementation research on antenatal care 8 contact model that was initiated last year in 4 countries, including Burkina Faso, Zambia, India, and Rwanda, in partnership with Bill and Melinda Gates Foundation. And I want to thank Jeff, who is on this panel, really for the support. I do hope all this will help us find better ways to implement strategies with potential health outcomes for mothers and their babies within those countries, but also beyond. These are the few reflections I wanted to share with you after this excellent presentation. Thank you. Over to you.
Thank you very much, Dr. Bucagu, and I'm sure we will all be eagerly awaiting the results of that work, and certainly do appreciate your highlighting both the importance of implementation research and this issue of innovation around antenatal care. Our next very distinguished speaker, and again, I need to also express our enormous gratitude to the Bill and Melinda Gates Foundation, who funded this work and were able to make it happen. And we are very fortunate to have Dr. Jeffrey Smith, who's an obstetrician gynecologist and the Deputy Director for Maternal Child Health at the Bill and Melinda Gates Foundation, and is really very pushing forward this agenda on group antenatal care and other issues, and we're very appreciative of that. So Jeff, I pass it over to you. Thank you.
Thanks, Dilys, and good morning to everybody, especially my friends in Rwanda. Good morning from Seattle. I really appreciate the opportunity to make some comments here, because this study by the team has really been an incredibly important study, and it has critical findings. And even though the intervention did not result in a reduction of preterm birth, these findings are very important, and we need to look into them and analyze them very closely. We all know that preterm birth is complex. Its causality is multifactorial. There are many different things that impact preterm birth. And while group antenatal care is a worthy and important intervention, it may not have impacted this cause of maternal or this cause of newborn mortality. But just because something is good, like antibiotics, and it doesn't prevent something that's important, like postpartum hemorrhage, doesn't mean that antibiotics are useless. And just because group antenatal care, which is a worthy intervention, didn't prevent preterm birth in this situation, doesn't mean that group antenatal care shouldn't be closely examined for its benefits. Therefore, context and intention really matter. And I think Sabine really presented critically important information about what did work and what potential there is in this situation. And I would really say that this work done by the team is just one example of how all of us really need to be thinking about transforming antenatal care. We have all known that the systems and structures that we use to provide antenatal care to women are not adequate. Women generally are dissatisfied with their antenatal care experience. They come, they wait in long lines, they end up with quick tests that they don't even understand the purpose of. They have very brief counseling, which often is not always counseling, but often lessons being pushed at women. And so really rethinking how we provide women antenatal care is critically important. This study really showed us several things. Dose is likely very important. The power of group antenatal care comes from the interaction between the providers and the clients. And that builds over time. You can't develop that trust, that interaction, that sense of openness and willing to discuss things with just a couple of visits. This team showed us that on average, they had about 3 visits, but that really is 1 booking visit followed by 2 group visits. And I think what we're seeing is that's probably not enough. And it's very, as Maurice said, there's more that we can learn about how to implement the suggested 8 contacts. And what does that mean? Can we come up with a combination of certain number of visits and a certain number of contacts that allow us to achieve a greater trust and greater impact? I really like Dillis's question about whether the impact is, what we're seeing is the impact on this pregnancy, or is it potentially on future pregnancies? Because what we, as I said, what we really need to do is think about how we change the structures of antenatal care and the potential of antenatal care. And I think if women find that they have a positive experience in this pregnancy, perhaps what they'll do is they'll come in earlier for the next pregnancy. They'll seek the confidence of the midwife earlier in the next pregnancy. And that's, I think, really important as well. I think what the study has also shown us is that the system is important. Health insurance factors can't be discounted. Provider incentive schemes can't be discounted. But now the Ministry of Health is willing to shift and look at the implementation of an 8-contact model. So how this fits into the ministry's vision and strategy really are important. And then maybe my last comment is that service delivery structures and obligations are important as well. If the same providers who are doing ANC are managing the labor ward, well, of course, a woman who's in labor is going to get precedence, and that's difficult to do. That doesn't matter if it's individual care or if it's group care. If the single midwife is pulled away for other clinical responsibilities, then that's important. So how can we think about adjusting those things. So perhaps something that another idea that's under consideration that was presented by the Lancet Commission on High Quality Health Systems about her service delivery redesign. How would that change things? You know, how do we think about segmenting where antenatal care is provided and where birth care is provided? So I'll close there. Thanks to the team for the excellent work. Thanks for elucidating critical lessons for us. And I think there's much more for us to learn. Thank you, and Murakoze.
Thank you so much, Jeff. Very happily, we have about 10 minutes that we're going to be able to open it up to question and answer. One thing that I did just kind of was sitting here reflecting on that you both alluded to, but this idea that, you know, COVID has been a blessing and a curse, and, you know, the innovation that is needing to occur around COVID is directly impacting antenatal care both positively and negatively. And I think that those of us in the field should figure out how to embrace that disruption rather than resist it, and see what positive things could potentially be carried on in this setting as in many others. So I'm going to pass the mic back to Dr. Stephen Relisa, who didn't get to fully introduce himself, so I will. He's a professor at the University of Rwanda and chair of the Department of Obstetrics and Gynecology. He was also the head of our DSMB for this study, so I just wanted to send a word of thanks to him for his role in that capacity as well, and for his support throughout. And he will moderate the Q&A session. Dr. Relisa.
Thank you. Thank you very much, Dennis, for introduction and for nice talk. I'll now open up to the rest of the audiences for any questions, if there's any. Meanwhile, if as a wait for the questions, maybe I have a question for Dennis, and maybe Dr. Maurice Bucagu. We also talked about Rwandan model to change it to 8 contacts. How do you foresee the change from this to 8 contacts? Is there any link? Is there a way we can link this up? Maybe Dennis can take up first.
Yeah, well, I think what I'm going to do is I'm going to immediately pass that hot potato, because I think that is that's a critical and critically important question that may better be in the hands of Felix, who is within the ministry and making some of those decisions. And at the same time, he can maybe, you know, incorporate into that a question that's coming from the chat about what is the government's plan around overall improving antenatal care, and you know, how are you going to include the community? You have a really strong community health worker workforce, and maybe just get some of your reflections on that shift from 4 to 8, and what the approach is really to addressing some of the quality issues in antenatal care. Felix?
Yeah, thank you very much. So there are a lot of efforts in improving antenatal care, especially in increase the coverage, but also the quality. We recently also adopted the new antenatal care guideline following the WHO recommendation, adopting the 8 contacts. And what we did, we tried to decentralize the services as much as we can. For now, the services can be offered at the lowest level of the administration entity, which is the CERB, meaning below the health center. And there they can also not only do the consultation, but doing also some lab tests. And we are discussing with some manufacturers how they can provide antenatal care panel, which can cover at once 4 tests, meaning malaria, HIV, syphilis, and hepatitis. But also we leverage on the experience with this study, especially in introducing ultrasound screening at health center, which we think will make more attractive antenatal care, but also will improve the quality especially in determining the gestational age. In addition, we have introduced the urine pregnancy test in the community. You know, the big issue, especially in increasing the attendance for antenatal care, is the area attendance. We have equipped community health workers with urine pregnancy tests so they can do the test in the community and ensure that the woman can visit the health center. So with the experience from this study, there are roads that we have learned. They were talking about human resources. We know it's a big challenge, not only for antenatal care, but with other services. But with the decentralization, we hope that there will be not a big number of women coming at that level because it will be decentralized. But for group antenatal care, as they said, this was a study. We learned a lot. And we think also doing like one with 8 contacts, probably one of the reason we did not maybe see what we were expected is that limited contact of women with the group antenatal care, which was only limited to 2 to 3. So, but with the new antenatal care guideline, I think the woman can be more in contact and we can see the results we may expect from the group antenatal care.
So
and
maybe
Dr. Relisa, I think we're going to probably need to wrap up here because I'm realizing we're at the top of the hour and many people need to move on to other meetings. So I don't know if you have any closing comment you want to make. I'm going to just squeeze in this huge words of gratitude to everybody in Rwanda and our funders, and I'm going to pass it over to Stephen to close the event, just understanding the time.
Sure, go ahead, Dave.
No, if you would like to close, I would, again, I'll refer everybody to the program report. I'd like to thank Sabine and Felix, and Stephen, if you'd like to go ahead and close.
Oh, mine would just to say thank you for everyone. Thank you very much, Davis and Felix and Sabine for leading this very, very important trial. And thank you very much for our guest, Dr. Maurice and Jeff. I know Jeff has woken up very early in Seattle, but you made the time. So thank you, everyone, and thank you for the participants. Thank you.